Good morning, everybody, and welcome to Insight 2021. The Midlands Decision Support Network, in association with the Strategy Unit, are hosting this Insight Festival, which is a series of learning and sharing events for the NHS, local government and other partners across health and care. Hopefully you've been aware that the festival's been running from Monday the 4th of October, and we're coming up to our final day, which is this Friday. The theme for this year has been Insight to Action, and we've been bringing together a range of inspirational speakers to explore how insights from high quality analysis can drive change in health and care systems. We're now in our final few days, but if you've missed any of the previous sessions, they're all available on the Midlands Decision Support Network website, so do check them out. Today we're joined by Dr Judith Dyson from the Improvement Academy in Birmingham City University. Judith's area of expertise is in implementation science. So once we've got the evidence and the data, how do we actually help people to do something with it and make a change? She's got a background in clinical practice, so she was qualified as a mental health nurse and a chartered psychologist, and her particular interest is how to use evidence to change clinical practice. We're really looking forward to hearing from her today. Before I hand over to Judith, I've just got a couple of housekeeping points. Please keep your microphone muted during the session. We will also be recording the session, which hopefully Zoom let you know about as you joined. We'd strongly encourage the use of the chat box, and I know that Judith's got some activities for you, so please do introduce yourselves and yeah, make full use of the chat function. And also, if you are a tweeter, please do tweet about how you're finding today's session. I know that Judith's got a Twitter handle, but I've completely forgotten what it is, I'm afraid. But also we're at the strategy _unit or at Midlands DSN. So yeah, do tweet us your thoughts on today. Without further ado, I will hand over to Judith to lead us through today's session. Thank you very much for joining us, Judith.
Lucy, I'm just going to try and share my slides and then we're ready to go. There we go. So what I'm going to do today is I'm going to basically deliver a little bit of a masterclass. So the title that Lucy kindly gave me was How Can We Support Behaviour Change in Practice? And as Lucy said, that's what I do in terms of my research, and I also work with practitioners out there through the Improvement Academy to support practitioners in understanding their clinical practice and all those things that influence the clinical practice in order to optimise it. So I'm going to do a little bit of a masterclass, and I'll pepper it with, I've cherry picked some examples that I thought the most entertaining from my own work and from other people's work. And I'm going to try and be technologically agile and keep an eye on the chat at the same time. So I think, as most of the people on the call will be aware, it takes around 17 years to get evidence into practice. That's an awfully long time. There are around 30 systematic literature reviews of techniques designed to improve practice, and what each of them have said through the ages, there are no magic bullets. So things like workshops, educational packages, reminder systems, prompts, all of those different things that we do to try and support optimal practice. Some things work sometimes in some circumstances with some people, but there are no magic bullets. So the bottom line is, when we're seeking for somebody when we're seeking to get evidence into practice, or we're seeking to improve practice, it generally requires somebody or some people to adapt or change the behaviour to do more of something or less of something. So going back to about 2005, not long after Jeremy Grimshaw's systematic review about what things we can do to improve practice, a group of health psychologists got together and said, you know, is our understanding of health behaviours something that we can start to apply in practice? Can we use the same theory to try and understand the things that get in the way for clinical practitioners? So that is basically what I do for a living. So whenever I'm seeking to improve practice, then I start to look at and speak to people and strive to understand those things that get in the way of their clinical practice or behaviours. Now, one thing that I'm going to say, when we talk about behaviour change, it sounds like if somebody's misbehaving, it might be useful, and that's not really it for me. And it would be useful if I knew how to do that, but I don't. So this is about understanding those things that determine our behaviours, and we can, another way of putting it is those barriers are facilitators to our clinical practice behaviours. Okay then, so what the evidence says then is, in order to support people in practice, we need to assess those individual barriers and facilitators, or those individual determinants. We have to tailor our interventions according to those determinants, and we need to use a theoretical approach to any interventions or strategies to support optimal practice. Now, the best way of me explaining this, I think, is to demonstrate. So I've got 4 quick questions for you, and if you could throw your answers in the chat, and I will try and find the chat and follow you. So the first one then is, what are your barriers to engaging in a health behaviour? Think about what you want. I've got a lettuce here, eating more lettuce, for example. What stops you eating more lettuce? Or think about exercise. What stops you from exercising more, or going to the gym, or what gets in the way of you stopping smoking, or substituting lettuce for chips, or chips? Yes, lettuce for chips. So in the chat, throw in all of your answers, and I'm going to try and find the chat. I'm sure it's here somewhere. Sorry. Now, sadly, I can't see the chat.
Judith, it's there should be if you hover at the top, there should be a bar that pops up which should have chat in it.
No, it doesn't. I've got participants, mute,
Yeah.
pause, share. Can you read it out, Rachel?
Are there 3 dots on the right hand side that if you click on them is chat there?
No.
Do you want me to, so I can read out what people are saying. I'll read some out.
Yes,
so time seems to come up a bit. Kids seem to come up as a barrier quite a bit. Motivation.
Motivation, good one. Yeah.
Chips are nice, lettuce is okay, somebody said. Lettuce needs washing. Other priorities, motivation, unfamiliarity or feeling that it's too difficult. Feeling fed up. Lettuce doesn't fill you up.
Oh, I really get that.
Yeah.
Brilliant. They're fabulous.
So there's been lots.
Thank you, Lucy. They're a great set of examples. Right, I'm going to ask you another question. And Lucy, if you wouldn't mind throwing some of the answers back at me when we do this. So the second question is then, I want you to pretend that you're a patient or a service user. And I want you to tell us, what are the barriers to you adhering to your treatment plan? So applying those emollients, or if you have asthma, using the preventer inhaler, or monitoring the peak flow. So type into the chat the things as a patient that might get in the way of you doing some of those things.
So we've got remembering is sort of popping up.
Good one.
Uncertainty as to whether it will actually help. Forgetting time, not fully understanding the benefits, confusing instructions.
Brilliant. Do you know what? This is the best group I've ever had. I don't know who you people are, and I can't see you because I've only got one screen, but you are the best group of people ever. Yeah.
Cost of prescriptions has come up as well. Actually, that's quite an interesting one. Cost. Not having treatment to hand, sort of availability, often in a rush, physical disability. So actually sometimes, side effects.
Yeah, that's enough. Good.
Yeah.
Fabulous. Thank you. So my third question for then is, so imagine that you are a care assistant or a doctor or a nurse or any secondary any secondary frontline practitioner, and type in the chat the things that get in the way of your engaging in hand hygiene. Sorry, there's a typo on that slide. So what stops you cleaning your hands before you touch the patient or before you do a procedure? Just throw all of those into the chat.
So again, time is coming up as a big one. Yeah. Rushing, might be an emergency situation. Somebody's put you can't see germs. Forgetting, inconvenience, sore skin, and actually the availability of facilities, distractions.
Brilliant.
Complacency. Somebody who end up with cold hands.
Who said complacency? Sorry, it's all
sorry, yeah, it's good.
Whoever said complacency, really good job. And if we were in a room together, you would get the prize for today. That's a great one. And don't worry, we'll come back to that.
Yeah.
Yeah. Final question then. So the final question then is, think about your institution and what strategies they take to support you in optimal practice, or what they do after a never event, say, or a serious incident. So again, just type in the box some of the things that your institution do to support you. Writing some of these down.
So the first person's put nothing. Clinical supervisions come up, training,
Yeah.
visual reminders, sharing learning, action plans, wellbeing conversations, training, audits,
Fabulous. That's
regular
brilliant.
meetings.
Brilliant. Thank you, everybody. You're doing a grand job here. Okay, so here's one that I prepared earlier. So with the Improvement Academy, sometimes we engage in doing training activities, and this is a question that I often ask, and probably have asked about 2,000 people now. Your answers were better than anybody that we've ever asked, and I'll tell you why in a minute. But this is to demonstrate why we need to use theory, we need to tailor our interventions, and why we need to assess those barriers. So the first thing is, these are the three first questions that I asked you about our health behaviour, our patients' concordance behaviour, or our concordance behaviour as patients, and then our implementation behaviour. The thing is, if we ask people what gets in the way of you practicing optimally, whatever that practice is, then people are subject to what we call cognitive biases. So, for example, the first one might be that they offer an automatic response. You know, they give you a knee-jerk reaction. So one of my colleagues, Sheldon Stern, he once did a survey of practitioners where he stood by the bedside, and when people hadn't cleaned their hands, he said, "Why didn't you?" Now, the problem with doing that is that he would get an automatic response, and they'd probably say, "I forgot," or something very simple like that. Another cognitive bias, if we don't ask the right questions, is that people will give a logical response, the thing that they think makes sense. So Socrates used to say, you know, the truth is within, we need to get to the truth. But very often, rather than digging for the truth, we say the thing that seems to make sense to us. Another cognitive bias, if we don't ask the right questions, is we all suffer from fundamental attribution of error. So if my boss says to me, "Judith Dyson, well done, you got that paper published, how did you manage that?" It's because I'm a genius. There's no two ways about it. This is the trouble with this way of talking, isn't it? I have no idea if my jokes are funny or not, and you probably have no idea that I am joking there. If she says to me, "Why didn't I get that paper published?" It's because the administrators are no good, because I haven't had time, because I've got too much teaching to do. So we attribute desirable behaviours to internal factors very often, and undesirable behaviours to external factors. So again, we have to ask the right questions. We have to almost give permission. Now, looking at these three questions I asked you, what I'm going to say is actually the same set of barriers, if you like, occur to all of these behaviours, exactly the same range. Now, that person who was a total genius that said complacency for our implementation behaviour is overcoming probably a social desirability bias. So that's not a cognitive bias, but a different type of bias. If you were to ask me, so I'm happy to tell you that I have rarely been without points on my licence, and I have been to 3 speed awareness seminars. I'm less likely to want to tell you if I've been caught drunk driving, aren't I? So the same applies to this as well. I mean, I'm quite happy to tell you that one of the reasons I don't like going to the gym is because my bum does not look good in lycra. However, am I likely to say I don't take somebody to the toilet when I'm working in practice because I'm complacent, because I can't be bothered, because I lack motivation? But actually, that person that said complacency is 100% right. You know, sometimes we do lack motivation. Immersion is something that's been in the literature in a big way recently in terms of our clinical behaviours. But as practitioners, we kind of think, very logically, we think we're entitled to be emotional over our eating. And you talked about lettuce not being as enjoyable as chips, for example. But we're not allowed to say that perhaps we're burnt out at work. Or is somebody speaking? Sorry, I thought someone was asking a question. Or that we're just too tired, or we can't be bothered. So again, by asking the right questions, we get closer to those right answers. So what I'm trying to demonstrate here is that we need to use theory to ask the questions, to assess the barriers, to get the right answers. I'm going to show you how in a minute. In the third column here, and this your answers went a lot different to this. When I've asked people what strategies their organisation offers to support them in terms of getting evidence into practice, these are some of the things that you said. And you had other things. You were talking about well-being, which is fabulous. I mean, that's really important, and shared learning, which again is really good. The point I'm making here, though, is our strategies have to address these barriers. So there's no point in now churning out educational meeting after educational meeting if the reason that people are not engaging in optimal clinical behaviours is because they're burnt out, or they're absolutely exhausted, or they're on the last legs, whereas your wellbeing meetings might well address that. So the final point I'm making here then is we have to tailor our strategies according to those assessed barriers. The third thing I said before I put this slide up was that we are more effective in supporting clinical practice behaviours if we assess barriers, if we tailor our strategies to those barriers, and the strategies are underpinned by theory. Now, I've not got a clever way of showing you that last one, but I am going to give you a lot of examples. But big systematic reviews demonstrate that if our interventions to support best practice are underpinned by theory, they're more effective. Okay. So this is the 6-stage process that I tend to follow, and just while I'm on this slide, if you Google Improvement Academy behaviour change, a whole toolkit will come up, and there's the resources that the team I work with and myself have put together that are free to use, and just have a good rummage and see if anything's useful for you. So forming teams, and I'm going to talk a little bit about co-designed and understanding barriers, but not so much about forming teams. Specifying and defining the behaviour. Now, this is really interesting because in actual fact we don't often do this in practice, but I'll say a little bit more about that, or we don't always do that. Identifying barriers, co-developing those interventions or strategies to address barriers, putting them in practice, and then evaluation. I'm going to say very little about evaluation, but let me focus on these 3 things mostly because these are the 3 things that we do less frequently when we're trying to improve practice. And again, I'm going to demonstrate all this. So the first thing is, very often, and you will start looking out for it now that I'm saying this to you, when we're in practice, we find that people tell us what goals we want to achieve, but they don't tell us what behaviours they want us to engage in to achieve that. So, for example, it might be that our institution's got a target to reduce inpatient falls. But it's unlikely that we're told that the reason that a lot of people are falling is because they've got ill-fitting slippers, or because they're older people and they're trying to get themselves to the toilet and they need some support, or there is a friend the other side of the room, you know, and what they want us to do on admission, make sure that that older person's got well-fitting slippers, for example. So the first thing, and I think this is the most powerful thing of all, in my experience of using these techniques, is to absolutely specify and define the behaviour. What action is it that you want, or we want somebody to do? Who is it that we want to do it? So is the person responsible for this action, or the person that's struggling with this action, are they the nursing assistants on an older person's ward, which is the context? Or is it staff nurses or qualified nurses in an A&E department? Or is it something much more specific than that? You know, is it something about co-disposal and infection prevention in sluices or something? Who is it we want them to do it with? or two, what is, who's the recipient, who is the patient or the service user, and when. So under what, kind of, is it during a medicine round, or is it when we're changing an IV bag or something like that, and how often do we want somebody to do that? I've put these little references at the end of all this, so if anyone's interested in the impact of doing these things, then there are references at the end. Now, so the first thing is specify and define the behaviour. Now, one thing that I really love about these techniques is I say anybody can do them, and this is one thing that I promise makes a massive, massive difference, and there's lots of evidence to support that in the literature. But it isn't always easy. So one project that I was engaged with a few years ago, and this was at Doncaster Hospital, and it was with the Maurice Madier, who was the Director of Infection Prevention at the time, and he came to me and he said, the problem we've got is junior doctors are prescribing antibiotics for non-confirmed urinary tract infections. This is the behaviour, this is what we want to change. But what I've gotten a little bit cautious with is thinking, well, is this the behaviour? Is this the thing that we really want to change, or is it about something else? And we all know about how to go about doing audits, and to know what to audit. This is one strategy that I find really useful, so process mapping. So I think, and this is very simple, it's just a demonstration, the process of, and using the example on the last slide, urinary tract infections, from beginning to end of treatment. So, and again, I know nothing about these things, so if I get words wrong, you'll have to forgive me. But the first thing is, do they have symptoms, the service user, so pain on micturition or a temperature, for example? If they do, then we dipstick. If they don't, then we don't. Is the dipstick positive to leukocytes or nitrates? If so, then we send for an MSU. We send urine for a midstream sample of urine for a culture sensitivity test. If not, we don't do anything further. Is it positive for infection? That midstream urine test. If it is, then we might prescribe an antibiotic. If it isn't, no further investigation. So how did Maurice know it was about the prescribing? Well, after we spoke, he went and he actually looked at the numbers and he did an audit. And the thing that was, excuse me, the thing that was going wrong, I'm going to have a drink. The MSUs were not being sent. So when the doctors were getting, going to see the patients, and they would look for the MSU result, it wasn't there in the notes. So using a precautionary principle, they would prescribe the antibiotic anyway. So what we needed to do was to make sure that the doctors had that result, and then they would or wouldn't prescribe an antibiotic based on the test result rather than a precautionary principle. And of course, I'm sure everybody on the call knows that prescribing antibiotics unnecessarily, can lead to disturbances to gut flora, and on a higher level, superbugs. So it's not desirable to prescribe antibiotics unless they're needed. So that was actually the behaviour that we needed to address. It was about getting the nursing assistants largely to send midstream urine tests when they'd had a positive dipstick. So that was what we worked with, so defining the behaviour. Now, in terms of assessing barriers then, this is where we start using theory, and I am going to come back to that example and finish it off. So if we're using theory to assess barriers, how do we go about that? Now, there are problems with using theory for us healthcare practitioners that are not health psychologists. This is one model that explains behaviour, the theory of planned behaviour. And you can see from this, there are three constructs that influence our intention, and then intention influences our behaviour, and this is perceived behavioural control. The PBC influences behaviour directly. So if we look at attitudes, subjective norms, perceived behavioural control influences our intention. Now, this is a model with just 4 constructs or determinants, if you like. So the first thing is, this is the simplest one that's out there, and this is the one that most healthcare practitioners know about, and this is the one that has been used historically the most frequently to understand staff and health behaviours in practice. But even this is a little bit dense. So when we talk about attitudes, what we actually mean in psychology is what we believe will happen if we do or if we don't engage in a behaviour. But common parlance suggests that attitude, often in practice, I hear attitude used like a really bad attitude. You know, it's kind of used in a less formal way. Subjective norms, I mean, it means what we're used to in that environment, or more broadly, subjective norms. So what happens on that ward, this is the way we do it here, what the other people around us do on that ward, what is expected in the hospital, what we're used to ourselves at home, how we've been brought up. You know, it's kind of a multi-layer staged exposure and so on. So even this, one of the simplest models, is really quite difficult and quite dense. There are 33 published models of behaviour or behaviour change, and if I say here we've got 4 constructs, I can tell you that in the whole of the published literature there are a total of 128. So suddenly we identify another problem. If there are 128 and we choose this model, then we're missing out on 124 potential determinants of behaviour, or things that could suggest barriers to us. So to cut a long story short then, this group of psychologists took all of those models, all of those 128 constructs, and synthesized it into this one framework. This is the theoretical domains framework. It's got 11 simple domains, and if you think about those great answers that you gave in the chat earlier, you can see how nearly all of your answers would fit in one of these domains on the left. So it's simple words that we all understand mostly to start with. There are only 11, they've all been synthesised. There are questions here, really simple questions to ascertain barriers. I'm not going to go through all of these, but you were saying things like complacency, that might be motivation, the 4th one down. Or you were talking about, you had some great environmental barriers, like the cost of medicine. So that would be environmental context and resources, if that was there in full. You don't think the creams would work if you put them on. That's beliefs about consequences. What will happen if I do or if I don't do this? A big barrier for many practices. You know, we don't necessarily always believe the literature. We believe what we say. And somebody says you can't see bugs, and that's absolutely right. So that might fit in there. Social influences. You know, what do the other people here do? What's the culture, immersion we've talked about already, and so on. Now, I'm going to say to you that you could apply this to any behaviours. Okay, I'm going to say not teenage behaviours, perhaps. Hormones are not on this list. I've got 5 children, so I'm pretty sure it doesn't work for teenagers. But these are all of the things, a comprehensive set of things that determine our behaviours. Now, I'm going to just put one more caveat on these. They're the things we can change. So there are some things that determine our behaviours that we cannot, or are difficult to change, or we would not want to change. So for example, Muslim women are less likely to go swimming. You know, we wouldn't want to change somebody's religion because going swimming might be a little bit healthy. Personality. So, you know, we know when we work with people with personality disorders, it's we can change, but it takes a long time. It takes a lot of effort. These are the things that we can change, and I'm going to say just keep this list with you. It will make you really patient. You know, kind of if you're in a leadership role, it is really nice to think of these things. If you're not really sure, I want to manage clinical psychologists. I'm sorry for the clinical psychologists on the call, but that was not easy. And I used to think to myself, why are they doing this really, you know, thing that in my position was undesirable? You know, what do they think will happen if, you know, have they got the motivation? Have they? But for a whole different set of behaviours, you can apply this. So this is probably the second thing that I've said that is useful. And again, if we ask these questions, then we dispel some of those cognitive biases. It helps us break through. People are more likely to answer. And practically, you know, you can have a conversation in a ward round, in a meeting. or you can send people a little questionnaire. And here I've put a couple of screenshots if you want to find resources. Again, they're on the Improvement Academy website. Feel free to have a look there. And for me, it's just, you know, getting a group of staff together and having that conversation with that framework in mind. Now, the next thing then, when we're assessing barriers, is you will not know them yourself unless you are the group in question and you are walking in the shoes of the group in question. You will not be able to guess. Now, I'm going to say that I've probably, well, definitely more than 40 projects, improvement projects in research or in practice in the last 10 years. I would go as far as to say probably 60 projects, and I've never been able to guess what the barriers are. So when we're assessing barriers, you have to talk to the target group. So I'm going to ask you again to put something in the chat box in a minute, if Lucy wouldn't mind calling some of the things out for me. So you know that example I gave you a few minutes ago about the nursing assistants that were they were doing the dipstick, the salt was positive, they were not sending a midstream urine sample for culture and sensitivity. So in the chat, if you wouldn't mind, just for a couple of minutes, why weren't they? What were their barriers? What was stopping them? And Lucy, if you wouldn't mind reading a few out.
Yeah, so competing priorities or changing priorities has come up as first. Don't know how, time, lack of training, urgent cases where symptoms in a vulnerable patient are severe, time, so time being a factor, not understanding the importance, seeing a positive result, so not really seeing the point of sending off.
Yeah, who said that?
Oh, it's gone. I've lost it.
Lost it. Well, whoever that patient is again is a total genius. Sorry, Lucy. Was it?
That's okay. Equipment, urine bottles in a different place. Patient not wanting to do it, has to be done in private by patient themselves under the instruction of the nursing assistant.
They're all brilliant. That's great. And again, which one? You know, I mean, you've all come up with all these different ones because, you know, some of you might know what it is if you are a nursing assistant and you are tasked with this and you are working, you know, in that environment. So if you are, whatever you said is likely to be right, and whatever everybody else said is less likely to be right. Now, in the end, what was right for this particular group in this particular environment in Doncaster, and you know, bearing in mind the older client group, was exactly what that person, that genius person said. You know, irrespective of the test result, the patient was getting treatment. And that's how the nursing assistant saw it. It was, well, why would we bother doing this? They're going to get that antibiotic that's good for them anyway. So we have got other priorities. We've got other things that we need to do, spend our time on, because they're going to get treatment. So there was a little bit about beliefs about consequences. What will happen if I do or if I don't? And thought it'd be exactly the same. They would get the treatment. And there was a little bit about knowledge. They didn't understand the harmful effect that antibiotics can have in some circumstances. So kind of knowing that, we were able to address that. So again, a big point here is just don't assume you know the barriers, ask the right people. So the first thing then, I'm going to recap, define the behaviour. The second thing, assess the barriers. When we're assessing the barriers, use that box, the theoretical domains framework, or something similar, so that people will tell you, I'm just up to here with it, and I'm just, you know, there's no room for anything else to do. I can't be bothered, you know, so you get those true answers and you can start to address them. What's coming up next then? Here we go. Now, I'm not going to linger here, so don't worry. But I've put this up just to encourage you, really. These are things that we all know as practitioners. These are not like really clever things. There is a taxonomy of 128 behaviour change techniques, which is pretty comprehensive. It's been revised and republished by different authors periodically. And here on this screen, I think I've got about 30. In this particular paper, which is at the back, there is a total of 44. And down this side here, you can see that there is a list of behaviour change techniques. We know these. Setting a goal, we know how to do that as practitioners. Monitoring, you know, we monitor a lot of things, and we have hand hygiene audits, for example. Self-monitoring, A contract, okay, this is more useful with some health behaviours than practice behaviours, but if you tell people you're going to lose weight, you are going to be more likely to lose weight. You know, and kind of the mere measurement effect, if we record what we're doing in terms of monitoring, we're more likely to change what we're doing. So those of us that have been to Weight Watchers in the past, start writing down what you eat, then just by writing it down, your behaviours change. I'm not going to go through all of these, but you can see we know how to do these. There are some complicated ones. There's cognitive restructuring. We'll forget it. If you don't know how to do it, just forget it. You know, there's lots to choose from. I'll come on to that in a second. We know how to encourage people, and motivational interviewing is on this list somewhere. It might be on the second page. But we know how to ask people what are the pros and cons, and you know that's kind of one of the key components of motivational interviewing. Right, so on this chart, the white square means it works. So this was a massive review of all these techniques. Under what circumstances do they work? So 2 is lack of knowledge. So you know those domains I showed you earlier, those 11 domains, that's these. And here at the side, there's a key to what they are. So 2 is knowledge. So if there is a lack of knowledge, what works? Let's find a white square together. Here we go, in a red circle, information. So if we don't know something, give some more information. It's obvious, isn't it? It's relatively easy. But look across, you can see information doesn't work for everything. So if we're not practicing optimally, don't just give information. If there are different barriers in place, you can see that information is not particularly useful if there's a skills deficit. Whereas 3 is skills. If there's a skills deficit, let's just go down to this one, rehearsal or practicing. So that's kind of, again, an easy one that works if the problem is skills. So all of those answers you gave fit into these domains. If you imagine them within the domains, you know, what are they, you know, what is the key domain? Then from that, you can choose the behaviour change techniques that work. And that's how we underpin our implementation interventions with theory. It's as easy as that. I put this blue arrow there because I thought it would please you as it pleases me. So look at role play. If we scroll across and we look for white squares on role play, none. You know, it's not known to be effective in any circumstances. Simulation is, but role play isn't. So if you're one of those people like me that goes to a workshop and you really hate doing role play, or you've got a great get out clause here. So this allows us to, so if we use the theoretical domains framework to either understand those barriers or to ask questions about those barriers, then we have got the opportunity to select behaviour change techniques. And frankly, those 3 things are everything that you need to know to be a health psychologist. That's really, I'm going to give you some great examples now, but that's all you need to know to do what I've been doing for 10 years. I'm going to give you one more caveat here. If out of those 3 things there's one thing you choose to not to do, this would be it. So define the behaviour and assess the barriers, and then tailor a solution that seems reasonable to you, that seems logical. If you can do this, all the better. But there's great debates in the implementation literature. I'm thinking Mark Nichols a few years ago about whether theory does or doesn't work. It does, there's no question about that, but what the outcome of that debate was that as people working in health, we know people sufficiently that if we think, okay, this is a barrier, what will we do about it? It's likely that we've hit on theory accidentally because we work with people, we understand people, we're logical, we're problem solvers. So of all of the things that you may or may not do from this talk today, say what the behaviour is, the way we've talked about it, and assess the barriers, and then think logically, or if you can, come to this.
Judith, we just, sorry, before you move on, we've just had a couple of questions on that previous slide. Somebody was asking what the blank versus stripy squares mean. So we were looking for blank squares. And also people are asking about which paper it's from.
Yeah, this is, it's referenced at the end. It's Mickey and colleagues 2008. The white squares mean it works. I can't remember what all the stripy ones mean. The black squares mean definitely not under no circumstances. And the little crisscrosses and the stripes mean kind of, it's a range of either probably not or might be helpful. So it's kind of a range. So the black one's definitely not, the white one's definitely yes, and the other 2 are somewhere in between.
Thank you.
So if we've got a load, like if you guys were all nursing assistants that were working doing midstream urine tests, and you told me all those barriers, now the first thing to say is you've got a range of barriers like that because you're all coming from different perspectives and different environments and different ways of thinking about things. But if I was to talk to you and you were all one group of practitioners and you all worked in the same place, then we might get kind of clusters of 2 or 3 things. You know, you wouldn't have such a broad amount of barriers. But once we have got those things, how do we decide? So the first thing is any knowledge deficit, address it. It's easy to do, you know, very simple to do. Just give people that information in any context, you know, if it's a ward round or, you know, whatever it is. So address it, because we know that knowledge is a prerequisite to behaviour change. On its own, it is unlikely alone to significantly change behaviour, but we kind of have to do it. So first of all, address any knowledge deficit. If there are environmental barriers, try and address those. So I'm really talking about kit here. So if, for example, some of my colleagues in the Improvement Academy did a big piece of research on nasogastric tubes and testing them with the pH paper, there'd been never events in Leeds, and when they unpicked those, it was because people were going to X-ray to see where the tube was, and then the wrong X-ray was being read or the tube was moving on the way back from X-ray. First line recommendation is pH paper, and they just didn't have the paper in this institution. They didn't have the kit, so a really simple task to just tick that off. Now, if the issue is time or competing priorities, then that's a whole different workshop, and kind of I'd be delighted to speak to people about that. It's been my life's work when I'm talking to people about managing time and priorities to steal all of their ideas, because that comes up a lot, of course it does. But after we've dealt with knowledge and kit issues, then just pick the biggest. So what are most people telling you about? Where is the emphasis? Who's, you know, really saying this is a real big problem? You know, pick the biggest. So, you know, if the issue is, you know, we don't do that here, or it's not my job. We've got somewhere here I'm looking for it. Role and identity, professional role and identity. It's not my job. It's the nursing assistant's job. You know, if that's the biggest one, pick that one and then address that, basically, is what I'm saying here. And then I'm just going to give you some cool examples of great interventions that I've come across, and then I'll pause for questions. And again, I've picked the ones I like the best because I think they stay with us, don't they? So once we've got that active ingredient, whatever it is, and I'll give you an example here in a second, turn it into something in practice that's pragmatic, that works. So you've got your active ingredient, the behaviour change technique. How are you going to use it? What are you going to do with it? And when I work with people, I say to them, stop being a practitioner now. Just pretend for half an hour that you are in a different job. You're here as a consultant. You know, you're in some glamorous industry like advertising or something. Get creative, because once you've got brilliant ideas, you can scale them into something that's usable. But the best, most effective interventions I ever read about are those that are a little bit creative. I've said here, don't get stuck in workshop postal land. That's the first thing that we all think about when we're seeking to influence practice behaviours. You can put some of those behaviour change techniques in workshops and posters. For example, you can have the voices of our service users. Here on this picture here, they're using a little bit of anticipated regret as a behaviour change technique. So, you know, you could have that slow down, and you could have the picture of the 2 kids at the top, or the mum and the child, if that's what it is. And that would give us information. But the minute you add a child's drawing, like we've got here, sometimes all of a sudden we've got that emotional impact as well. You know, these poor kids, if we, you know, we're thinking about the consequences of our behaviour, not just information, slow down here, we've got to slow down, but what might happen if we don't slow down? What about them poor kids that are, you know, that are dead, or that are maimed by our fast driving, and so on. So the best interventions to support practice behaviour are those that are a little bit creative. So one that came about across years ago in Hull, and again, it was I do quite a lot of infection prevention work. I like infection prevention people. They're very patient people, I think. They've really had it hard, haven't they, recently? So about a decade ago, when we were in the MRSA and Clostridium difficile was really high, outside the intensive care unit in Hull, they had a traffic cone. And as people walked past it, the cone was activated and it said, "Please clean your hands." Now, the cone would work if the barrier was people forgot, because really it's a prompt, isn't it? That's its mechanism of action. Its active ingredient is that it reminds people or it prompts them. So if people forgot, which is very likely, you know, you kind of get into automatic behaviours and you're rushing for something and you're focusing on something like, you know, the patient in ICU that you're going there to see, then that would work as a behaviour change technique. And it's accessible, it's easy, it's cheap. One thing I've got here, and again, this was infection prevention, it was in Harrogate, and this really wonderful woman, Kath Banfield, who was the infection prevention lead in Harrogate at the time, told me that she had MRSA recorded to the tune of YMCA. Now, if you were in a room, I would ask, does anybody want to show us what that is and sing it? And somebody would. But as we're not in a room, and I'm not going to do it, but you know that song where they do all the actions, and on the hospital radio, kind of as an awareness raiser, as a different way of getting the message across. And again, I've just put some pictures here, they're not mine. So again, you know, this ice cream, I mean, there's no doubt just at a glance, you know, a second, this intervention takes a second, what will happen if you eat ice cream, is there? And again, look at this one about text driving. You know, is your driving as bad as your text is if you were doing both simultaneously? You know, and you can see that they could have quite an impact. In Leeds, again, this was for hand hygiene, they gave people rewards. So the behaviour change technique here is reward. So they gave people a certificate and a day for extra days annual leave. Now the certificate actually is a little reward, but its main mode of action is recognition and social reward rather than the day's annual leave, which is much more tangible, practical reward. I worked with a group of doctors up in Airedale, and they basically said, if sister tells us to do anything, we'll do it. So, you know, anything we wanted junior doctors to do at that time, we just got sister telling them to do it. This one is one of my favourites, and it's a paper that was led by somebody called Judah. And again, it was during a previous epidemic. It's not that old, I think it's less than a decade old. But it was during a previous epidemic, or maybe it was flu season, and it was motorway service stations, and they wanted to increase the public's hand hygiene. So above the urinals in the gents' toilet, they put one of those screens with a message on, and the message was, "Will the person next to you clean their hands?" And soap usage went up fourfold. And that simple message, you know, if we're bothered about what other people think of us, then that would work. So if we're somebody that, you know, our reputation, for example, is important to us, and you know, other people's thoughts on us would be important, and it would work. And finally here I've got one which wasn't a real intervention, it was an accidental intervention, I'm going to call it. So again, this was, you know, I collect all these brilliant stories. It was somebody, again from Doncaster, somebody called Jo was telling me this, and she said that she was working on a ward and she was in charge of a 4-bedded bay. And one of the patients said to her, you know, "Can I have a word?" And she went across and she said, "Look, I know that there is confidentiality and you can't tell me about another patient, but I'm really worried about that woman over there. I'm worried that you know, she's really contagious and I get an infection, because when the staff go to her, they're cleaning their hands, they're putting things on, they're putting gloves on, they're cleaning their hands again, they're gelling, they're doing all this, whatever she's got, I don't want to get it." The woman in the opposite bed was the lead for infection control and prevention in that hospital. You can see, can't you, when you start to think psychologically, the smallest things can influence our behaviour. And the procedure that I've just talked you through seems really formulaic, but if you follow that procedure and you know the kind of behaviour change techniques or what you're seeking to address, these are some of the fabulous, cost-effective ways we can support our practitioners in improving their practice behaviours.
Judith, we've just had a couple of questions, or two, sort of the same question twice. Is there any research into how long these interventions work? So, for example, with the talking cone, like, do people just kind of get used to it and then stop? Does it like lose its effectiveness?
Yeah, really good question. And again, you know, that what you've just said is a really fabulous and common sense answer. Yeah, it becomes wallpaper after a while. So when screensavers are a good example of this, we've got to change them quite frequently before they do become wallpaper. And that is largely the strategies with the shortest expiry dates tend to be prompts. So we do have to change those. But bear in mind also, once we've got somebody doing something routinely or habitually, then it tends to stick. And again, the time it takes to get somebody to embed something into the routine practice depends on how frequently they would engage in that behaviour. So on the one hand, that question is a brilliant question, and you're absolutely right. And I'm sorry that my answer isn't clearer. The answer is it depends on what the strategy is, but yes, certainly environmental prompts and images expire first. And how long does it take to embed behaviour? Well, again, it depends on how frequently we do it. So for that, common sense, use common sense, but you're absolutely right, and that's a great question. Almost finally then, I've just got a couple more slides. Maybe I'm going to show you toilets in a minute. It's always good to end on toilets. So here I've got a handbag which is neat. Apparently it's supposed to be neat. And when you're doing an intervention, just think about these parameters. You know, is it affordable? How much time does it cost to have, you know, a group of practitioners in an educational workshop, and who delivers it, and what's the cost of that, and what's the opportunity cost later down? And we think about that in terms of safety. If we are having somebody do X behaviour, if we're trying to get people to do more of something, what's the impact of that? Is it going to mean they're doing less of something else? Now, I think we all know that optimal care is efficient care. So if we're getting it right and we're doing it the first time, it saves a lot of time and a lot of money downstream. But still, it's still important to think about the opportunity costs of encouraging. If we are seeking to improve practice behaviours, it's got to be worth it. It's got to be something that's evidence-based and it's going to make a big difference to people. And I think the other things go without saying. I mean, for me, this wouldn't be affordable. It's not practical because I couldn't get my stuff in it. And I'm a vegan, so I wouldn't want a handbag that looks like meat. It's in terms of acceptability. So again, just another quick little acronym to help us as we're thinking about these things. Why co-design then? Now, this was, again, another piece of work that I did with Morris in Doncaster, and it was an improvement piece of work. It wasn't research. So basically, he had the opportunity to test out some of these electronic hand hygiene monitoring and prompt systems. And I'm keeping an eye on the time. I'm going to tell you this really quickly. Basically, staff had a badge, and when they went into a bay, there was a monitor on the ceiling. It activated their badge, and if they hadn't cleaned their hands within however long, the badge started beeping. So did it work? What did people think about it? Was it useful? Now this is the graph that we put together to measure this. Now look at this. So the electronic device in orange was measuring almost 100% hand hygiene throughout it being adopted. Look at blue. Blue is the hand hygiene audits, the observation, that's gold standard. And you can see there was some times where it was up there. Now these orange ones, we were recording it all the time, 24 hours a day, whereas blue ones were just when someone was there. So we've got pathfinder factor, so probably people do it better because there's someone there. But look, you know, even the observations weren't getting as many as the electronic device, and observations are better. They're gold standard, and you can see we've got alcohol gel use there as well, but you pretty much ignore that. Anyway, we did a qualitative piece of work alongside it, and people were telling us they cheated. They didn't like it. They felt patronised. You know, we've got this device telling me when I should clean my hands. You know, am I not trusted as a practitioner? And there was one nursing assistant that told me that she gel her hands. The badges were reactive to gel, so you put your hand over the badge to let it know you clean your hands. She'd gel her hands, and then she'd help everybody out by doing their badges. If we don't co-design with the practice, the target group, they're not going to be acceptable interventions. And this is my toilet borrowed from a colleague, and this is another example of that. So I'm going to tell you the answers here. You can see on the first toilet, the flush is there and you can push the button on the flush. On the second one, in order to flush the toilet, you've got to put the seat down. So I'm sorry if this sounds really sexist, so maybe for men to put the seat down. But of course, if this is something that hacks us off, we're just going to move the seat, press the button and leave it up again. You know, we've got to engage with strategies. They've got to be acceptable to us. Final slide then, and then I'll ask if there's any questions. In practice, when it comes to evaluation, and I know that the West Midlands Commissioning Group's got some great stuff on evaluation on their website. We have to be a little bit more creative than we are when we're doing research. And if we're seeking to change practice behaviours, think about those practices and how we might capture them. If we've got a strong logic model, so if we do X to support somebody, they will then do Y, and then the outcome is the patient will be better, will be fewer falls or whatever. Then we can, you know, as long as we know this is going to happen and this is going to happen, if we do this to help people, then we can be creative. So this is a photograph which is one of my ex-PhD students, tailor, is now working at Staffordshire. She did a piece of work on hand hygiene in Nigeria. Now this picture speaks a million words, doesn't it? And again, in terms of infection prevention, actually environmental observations are something that is promoted. I mean, these people, well, even in Nigeria generally, according to our literature review, are adhering to hand hygiene as well as we are in the UK. And look what they've got to contend with. No hand paper towels. Sometimes they don't have running water, there's only cold water. And kind of, so this is where I want to finish really on a really positive note. There is something about positive deviance where people are really struggling, but they're doing it anyway. And when we're thinking about behaviours, because I haven't said a lot about facilitators, find those people that are doing a magnificent job against the odds and speak to them too. So my last kind of message really before I shut up and ask if there are any questions is, you know, I've talked a lot about addressing barriers, and that's a great starting point, but look at what people are doing well, try and work out why they're doing it well, ask them, and absolutely celebrate it. Final point, all of us in practice, there's, you know, all right, we've got Harold Shipman, put him to one side, we're all out there doing the best we can for people. This isn't that we are deviant in some way, that we don't want to do our best for patients, but there's an awful lot of barriers out there, there's an awful lot of things that get in the way, and we can address them. There are things that we can do. Okay, so that's all I've got to say, and I think we've got about 4 minutes left if there are any questions, Lucy.
Thank you so much, Judith. That was really great. And I haven't got any questions in the chat box yet, but people are saying thank you. So that they've really enjoyed the session. Yeah, I was going to say you've put your contacts there.
Yeah, and stay in touch, people. You know, if you're doing any improvement projects and you want to talk to me, I'm always fascinated. Oh, you've got some great strategy, please email me, and rest assured that your story will pop up on some talk that I'll do in the future. But yeah, it'd be great to hear from anybody that's interested. And there's references at the end.
Great. We will, I think we'll be sharing the recording obviously via the website, and I think we're okay to share the slides, Judith.
Yes, absolutely.
Yeah, so we're great to share the slides. Somebody's put that they loved this session in capital letters. Thank you so much. Really enjoyed it. So thank you so much, Judith, for taking us through. That was really interesting and really informative, and really loved it. I'll just do a quick update on so for those of you that want to know what's going on for the rest of the Insight Festival, bear with me 2 seconds. Let me just share what's coming up later on this week. So tomorrow we've got a session on misinformation and how do we tackle it with Professor Stephen, forgive me if I'm sort of murdering the name, Lewandowski, Dr. Ruth Carlisle and Trish Lacey. And then on Friday, we've got our final session, rounding up Insight 2021. And we've got a panel of Richard Murray, Jennifer Dixon, Nigel Edwards, John Glasby and Peter Spilsbury, talking about Insight to Action. And so please do join those sessions if you can. And thank you very much for coming today.